Good evening, sir. Good
Good
evening,
evening.
Peeyush. Good evening,
TD,
sir.
the first three speakers today have 20 minutes each,
Yes,
and
sir.
then half an hour for the surgical part, and then we will have half an hour open house. But before the open house, I have requested Peeyush, as I said yesterday, to make a small presentation on HPB tuberculosis.
Oh, yes, sir.
Good evening, everyone. It is 7 o'clock. So we start the second part of our ninth masterclass on abdominal tuberculosis. For those who were not there yesterday and who are watching this video today for the first time, these masterclasses are part of Jaipur Surgical Tutorial, which is an online academic activity which we have been conducting at the Mahatma Gandhi Medical College and Hospital for last 3 years. And this is being coordinated by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery and liver transplant at my institution. In the Jaipur surgical tutorial, we conduct a session every Saturday, 9 to 10 a.m. Indian time, which is online. And in addition, recently we have started a Jaipur surgical school, which is on Friday afternoon, 3 to 4 p.m., which is mainly for our colleagues and students in Africa who could not join the morning sessions. So the Jaipur Surgical School is being looked after by Dr. Peeyush Varshney, who's at the AIMS Jodhpur, and Dr. Kailash Kodia, who's at AIMS New Delhi. And these master classes we do last Thursday and Friday of every month, 7 to 9 p.m. We cover one topic in two parts of 2 hours each. We've already conducted 8, and this is the ninth master class which we are doing now. In between the sessions, I will project information about as to how new students and new colleagues can join these educational activities. You just have to send a WhatsApp message and then you will get all the information about these activities. So to moderate this session, I have my colleague, Dr. TD Yadav, who is a professor of GI surgery at Postgraduate Institute of Medical Education and Research in Chandigarh. So over to you, TD. Maybe I'll introduce the first speaker because you may not know. Dr. Chetna Mehrol is my colleague in the Department of Pathology at the Mahatma Gandhi Medical College and Hospital. And she is going to talk to us about the histological diagnosis, the point which we were discussing yesterday. And Dr. Sitaram and other speakers also emphasized that although radiology and endoscopy is highly suggestive, but to treat with anti-tubercular treatment, we need a histological diagnosis, and also because it is a great mimic, as we saw yesterday, to make sure that we are not missing malignancy. Again, we need a histological diagnosis. So Dr. Chetna is going to tell us about the histology of tuberculosis. Chetna, please.
Good evening, everyone. Thank you, sir, for the kind introduction. Sir, I'm not able to go to the next slide.
नहीं, आप इसको वो करो, full screen करो.
Sir, it is full screen only.
अच्छा, नहीं, हम तो maybe then stop sharing and share again.
Presentation mode पे जाना होगा, sir. You go on presentation mode. Just click on presentation mode. It is a
presentation mode. Where it is, sir?
ये फ्लावर जहाँ बना हुआ है ना, नीचे एक फ्लावर बना होता है. अगर आप देखो बाहर जहाँ पे लिखा है ऑफिस थीम इंग्लिश वो यूनाइटेड स्टेट्स, तो यू विल फाइंड देयर इज ए फ्लावर टाइप थिंग. दैट इज प्रेजेंटेशन मोड. जस्ट क्लिक ऑन दैट.
नहीं, वो आई थिंक चेतना के स्क्रीन पे ऑलरेडी है, उसमें हमें नहीं दिख रहा है. आप चेतना स्टॉप शेयर करके दोबारा शेयर कर लो.
ओके सर.
Sometimes it happens. So we also welcome Dr. Sitaram, who was the former chief of HPB surgery at CMC Vellore, and my colleague Dr. Sanjay Gambhir, who is the chief of nuclear medicine at SCPGI in Lucknow.
Now can I share again, sir?
Please share.
Is it okay?
Yes, yes. Again, go to the full screen mode, the presentation mode. आपकी स्लाइड चेंज हुई है?
Yes, sir. Yes, sir.
ठीक है,
Yes.
स्टार्ट. ठीक है, it's okay. You can go on in this.
Good evening, everyone. So, thank you, sir, for the kind introduction. So, I will be talking about histopathological diagnosis of abdominal tuberculosis, mainly focusing on the diagnostic features. Also, I will be talking about histopathological diagnosis of Crohn's disease. Again, the key diagnostic features and the differentiating features between the two, as the Crohn's disease is one of the closest differential of tuberculosis. So, few words about abdominal tuberculosis from pathology point of view. It's an infectious disease of colon or small intestine caused by acid-fast bacilli, Mycobacterium tuberculosis. Although the GI tuberculosis constitutes 10% of extrapulmonary tuberculosis cases. Most commonly, as we have studied also, the ileocecal region is the most common site, followed by jejunum and colorectum. However, the isolated colorectal involvement is uncommon. The rectum and anus are rarely involved, as the anus represents only the 1% of abdominal tuberculosis. So the most common site for now is ileocecal region. So talking about pathophysiology, most common route of infection is by ingestion of infected unpasteurized milk or by ingestion of the infected sputum. Secondarily, it can be spread by the hematogenous route by any tubercular foci elsewhere in the body, sir. Why ileocecum? The point is because the ileocecum is the site having abundant lymphoid tissue. So the type of hypersensitivity reaction which is responsible for the pathogenesis here is cell-mediated delayed type hypersensitivity reaction. So in short, what happens?
डॉक्टर चेतना,
Yes,
आपकी
sir.
स्लाइड मूव नहीं कर रही है.
स्लाइड मूव नहीं कर रही है?
हाँ.
Sir, it is moving from my end, sir.
बट हम लोगों को वो फुल स्क्रीन मोड नहीं दिख रहा है, हमारे में यही वाला आ रहा है.
नहीं, आई थिंक फुल स्क्रीन मोड पे गए नहीं वो, नहीं तो सर वही दिखेगा. सी द स्क्रीन वी आर सीइंग इज व्हाट सी इज प्रेजेंटिंग. वो साइड
नीचे बॉटम में जहाँ 70% है, नीचे लिखा है, उसके लेफ्ट में जो आइकॉन है उसको क्लिक करो प्लीज.
Sir, again, I'm seeing a panel at the top of my laptop where there is these instructions: mute, stop video, security, and all. Again, I will stop sharing and share again.
नहीं, आप नीचे देखिए, बार पे नहीं, आप नीचे देखिए. नीचे जहाँ पे डाउन है, नीचे आप देखोगे तो लिखा स्लाइड नंबर्स, ऑफिस थीम, इंग्लिश. देन गो टू द लोएस्ट पॉइंट पे जहाँ पे 70% है, उसके लेफ्ट में एक आइकॉन बना हुआ है.
Sir, it's not coming in my laptop.
नहीं,
sir.
आपके लैपटॉप पे ऑन योर.
Sir, I'll do it again, sir. Once.
हाँ.
Sir, there are two options while sharing: share sound, optimize for video clip.
You just share the entire screen and
Okay.
yeah, and then just make your presentation full screen.
Is it visible?
But it's not full screen. The second slide is there.
Now?
ऊपर भी लिखा है ना, पावर पॉइंट का जो है उस आइकन है, उस पे भी लिखा है. आप जाओ स्लाइड शो पे, तब उस पे आ जाएगा फ्रॉम स्टार्ट या फ्रॉम द प्रेजेंट स्लाइड.
नहीं, ये प्रॉब्लम कई बार होती है, जो प्रेजेंटर है उसके में फुल स्क्रीन होता है बट यहाँ नहीं आता है.
Sir, it is full screen on.
हाँ, या आई नो, आई कैन सी. पहले भी हुआ है कुछ लोगों को प्रॉब्लम. अब अभी आप कौन से स्लाइड पे हो? वी कैन सी द सेकंड स्लाइड.
Okay, the content slide you people are seeing.
Yes.
Content to be covered. Now move to the next. Now we can see full screen. Yes.
Oh.
Good.
Sir, is it okay now?
Yes, yes, yes.
Okay. I will be covering about the histopathological diagnosis of abdominal tuberculosis, mainly focusing on diagnostic features. Also, I will be talking about histopathological features of Crohn's disease, which is one of the closest differential after tuberculosis, and the differentiating features between the two on histopathological grounds. So, a few words from abdominal tuberculosis from pathological point of view. It's the infectious disease of colon or small intestine, as we all know, caused by acid-fast bacilli, Mycobacterium tuberculosis. And the GI TB constitutes about 10% of all extrapulmonary cases. So ileocecal is the most common site, followed by jejunum and colorectum. However, the isolated colorectal involvement is uncommon, sir. Rectum and anus are rarely involved, as anus represents only 1% of abdominal tuberculosis cases. So I can't go on the next slide.
ये प्रॉब्लम कभी कभी होता है, कुछ सिस्टम इनकम्पैटिबिलिटी। तो आप इसमें एग्जिट कर जाओ, जो स्लाइड मोड है, शो प्रेजेंटेशन मोड में, उसी में चले जाओ आप।
If you can mail the presentation to one of us, we can run it.
हाँ, पीयूष को मेल कर दो आप। आपके पास है पीयूष का एड्रेस?
I'll just drop in the chat box, sir.
अच्छा, उससे भी खुल जाएगा?
Yeah, I'll just drop my email ID, sir.
अच्छा,
Once again, I'm trying again.
हाँ, तो आप पीयूष को मेल कर दो। पीयूष ने अपना ईमेल आईडी आपको दिया है।
Okay, sir.
So maybe what we can do in the meantime, we can move with the next topic, can we?
तो कर सकते हैं सर। इन द मीन टाइम अगर
आयुषी ने अभी ज्वाइन नहीं किया है। आयुषी is actually abroad. She said she will be joining.
So I'm here. I've joined.
Oh, you are there? Good, good.
Yeah.
Sir,
Are
I'm
you
just
ready?
sending it.
Sure, sir. I'm
Yeah,
ready.
please.
देखो आप आयुषी, आप ट्राई करो।
Sure. It's saying only the host can share in this meeting.
Himanshi, can you please make Dr. Ayushi Zoom? She's logged in as Zoom user. Please
Yes,
make
sir.
her
Yes. Just a minute.
a co-host. Yes, Ayushi, now you are a co-host.
All right, sir. Sir, can I share my screen? I can't
Yes,
get the
yes.
option of sharing my screen. I'm just getting
No.
photos, iCloud Drive.
At the bottom, you don't see a green icon, share screen?
No, sir.
Sir, I've sent my presentation.
हाँ, पीयूष आप देखो।
Dr. Peeyush, can you please check?
Till now, I haven't received it. I'm just refreshing it. haven't received the mail yet. Yeah, I got it.
It has been sent from my side.
Yeah.
To Peeyush.
Just wait. I've received it. I'm just downloading it.
Yes. Yes.
Oh, yes. So shall I?
जब कहोगे तो मैं stop share कर दूंगा.
Yeah, shall I share my screen, sir?
Yes, yes, please. All right.
Is it visible, sir? So let me make full screen. It's visible.
हाँ, ठीक है.
Okay, so I am moving. Is it moving, sir?
Yeah.
Yes, yes.
Over here
So
we
let's-
will cover.
Yeah. I'll just move it. Just let me know next.
Yes.
Okay.
From here, should I start again?
हाँ, please.
Okay. So talking about abdominal tuberculosis from pathological point of view, it's the infectious disease of the colon or the small intestine by acid-fast bacilli, Mycobacterium tuberculosis. The GI TB constitutes 10% of all cases of extrapulmonary TB. The most common specimen, the resection we got are ileocecal regions only, followed by jejunum and then the colorectum. However, the isolated colorectal involvement is uncommon, whereas the rectum and anus are rarely involved, as anus represents only 1% of extrapulmonary cases. Next. So the most commonly, the abdominal tuberculosis is caused by ingestion of infected unpasteurized milk or by infected sputum. The second most common pathway is via the hematogenous route from the tubercular foci elsewhere in the body. So why ileocecum is the most common organ involved by the abdominal tuberculosis? It's because of the abundance of lymphoid tissue. So the cell-mediated delayed type 4 hypersensitivity reaction is responsible for the pathogenesis. So in brief, the bacilli are first phagocytosed by the macrophages. These macrophages release some factors. The most important ones are the interferon gamma. These interferon gamma, this causes the blockage of phagolysosome, because of which there is continuous replication of these bacilli, leading to bacteremia and ultimately resulting in primary tuberculosis. So in pathology department, when we talk about histopathological examination, then we receive two types of specimens in relation to abdominal tuberculosis. First, we get small biopsies, which are the endoscopic mucosal biopsies, and the second, we have the resection specimens. So talking about endoscopic biopsies first, the tissues we receive in our department usually varies from 0.1 centimeter to 1 centimeter in greatest dimension. We usually completely processed it, whole summated it, and we have to look for two features in small biopsies. Here I'm making a very important point. The two features which we look in small biopsies are, first is the crypt morphology. Second is the presence or absence of epithelioid cell granuloma. So here comes two scenarios. The first scenario says if the crypt morphology is normal and there is presence of epithelioid cell granuloma, then it is hinting towards tubercular pathology. That is scenario number one. Whereas the second scenario says if the crypt morphologies are altered, that means if the crypts are distorted and if you can see the signs of activity, that means crypt abscess are there, cryptitis is there, along with it you are seeing granuloma, then in that case also it will not rule out the possibility of tuberculosis. Rather, in that case we give it as chronic granulomatous inflammatory pathology, keeping the Crohn's as secondary differential. Now, in that case, we usually talk to our clinical friend and we ask for repeat biopsy and also look for the endoscopic findings and clinico-radiological correlations. And one more important thing which I would like to mention here is usually the caseous necrosis, which is a diagnostic hallmark for tuberculosis, is usually not appreciated on small endoscopic biopsies. So in that case, we usually give it as If the granuloma is there, chronic granulomatous inflammatory pathology. And in that case, the final diagnosis is usually made on the resection specimens. So grossly, the abdominal tuberculosis are of 3 types. The most common is the ulcerative type, which comprises of 60% of the cases, followed by ulcero-hypertrophic type, which is 30%. And the last is hypertrophic, which accounts for 10% of the cases. Usually, the tuberculosis has transverse ulcers. That means the tubercular ulcers are multiple. They are usually superficial. And what do we mean by transverse? They are usually perpendicular to the long axis of the bowel. Then you can see mucosal folds, which are thickened fibrotic walls, the stricture formation, and the inflammatory nodules within the mucosa. So these are the gross photos of intestinal tuberculosis. First, I have told the most common one are the ulcerative type. As you can see, marked by the arrow, we can see this ulcerative mucosa. This is the cut open specimen of a bowel. From the mucosal aspect, you can see marked by the arrow, there is this presence of ulceration, whereas on the adjacent, the mucosa is completely normal. Although it is little edematous. On the second hand, you can see hyperplastic type, you can see there is hypertrophy. You can see the inflammatory nodules, which is the second most variety of presentation of abdominal tuberculosis. Now, again, this is the ileocecal resection specimen, the cut open specimen of ileocecal resection. As you can see, there is presence of appendix and there is adhesion of ileum along with cecum. So you can see there is a thickened fibrotic wall, which is marked by the arrow. Next, on the serosal aspect, you can see these multiple gray-white nodules and tubercles, which are diagnostic hallmarks of tuberculosis on the serosal aspect. And in the second image, you can see on the mesenteric side, there is involvement of the lymph nodes. And the cut surface shows presence of this gray-white foci, the caseous cheese-like material, which you can appreciate in the lymph nodes marked by the arrow. Okay, now talking about microscopy, taking sections from that, in figure 1, you can appreciate the most common organ I've talked about it, ileocecum. So we have to identify whether the section is adequate or not. So check for the adequacy. We can see there are presence of these lymphoid follicles, which are nothing but the PS patches, which indicates that this section is from the ileum. Okay, now on the right hand side in figure 1, you can see these are the benign mucosal glands, and within the lamina propria, you can see the granuloma formation, which is the caseating epithelioid cell granuloma along with Langerhans giant cells. I have marked it with arrow. So there are 3 things which you can appreciate in figure number 1. First thing, there are presence of this lymphoid follicles on the left hand side, which is just the collection of lymphoid aggregate, indicating it that this section is from ileum because these are PS patches. On the right hand side, you can see the benign mucosal glands, which are just crypts, and there are presence of these granulomas marked by the arrows. In figure number 2, again, it is the hyper view from another focus. You can see a clearly visible granuloma present within the mucosa and submucosa marked by the arrow. Now, these are the HE pictures from the mesenteric lymph nodes. You can see from the mesenteric lymph nodes, now you can just imagine these are the pinkish amorphous granular material is just caseous necrosis marked by the arrows. So the upper figure number 3 shows extensive areas of caseous necrosis and granuloma. The lower figure is just the hyper view of the same, indicating again the granuloma and pinkish amorphous eosinophilic caseous necrosis. And if you can appreciate, there are presence of these Langerhans giant cells. The Langerhans giant cells are characteristically horseshoe shaped. By horseshoe shape, I mean the nuclei are present at one pole, whereas the other pole is empty. Yeah, marked by the arrow. And the caseous necrosis is this pinkish material, which is amorphous because it has got no shape. Second, it is granular. When we look at the slide, it is a little granular, and this is eosinophilic. And presence of these Langerhans giant cells, which is the diagnostic features of tuberculosis. Next slide, please. Now, these are the figure number 5. These are the Zn stain to confirm the presence of AFB. Although I would like to mention a very important thing here, GI tuberculosis is a paucibacillary disease and AFB might not be identified from variety of clinical specimens. So absence of AFB does not rule out tuberculosis. So in that case, we have to go with the morphology and we have to correlate clinico-radiologically, sir. So in Zn stain, you can see the bright red rod forms. These are the bacilli which are looking bright red and they are present in a background of necrosis, which is all bluish. Now again, the second picture is showing, marked by the arrow, clusters of these bright red rod forms. This is from the mesenteric fat. That is why it is a little acellular. And the upper image is from the necrotic background, highlighting the bacilli. So I have talked about that if the crypt morphology is normal, but you are seeing granulomas, then in that case, the first differential that comes into our mind is Crohn's disease, because Crohn's also involves the terminal ileum and cecum region, but to call it Crohn's on small biopsies is a little tricky. So we give it as chronic granulomatous inflammatory pathology, and for that you have to correlate clinico-radiologically, and the resection specimen is must to call it Crohn's, because in Crohn's, you are having skip lesions. The pattern of distribution is very important for the disease. So the skip lesions are only seen on resection specimen. So these are some drawbacks of small endoscopic biopsies. And a few words about Crohn's. The pathogenesis is poorly understood as it is idiopathic. It is one of the spectrum of idiopathic inflammatory bowel disease. And in Crohn's, grossly, we have linear and serpiginous ulcers, which are intermixed with the non-ulcerated mucosa, giving it a cobblestone appearance. And in Crohn's also, as I've told you, the granulomas are also there, but how they are different from tuberculosis granulomas are, they are non-caseating ones. So, and in Crohn's, the very important, which I routinely do, I always call and ask my clinician friend that whether the rectal involvement is there or not. Because to label it as Crohn's disease, to give it on the resection specimen, I have to be very sure that Crohn's start from terminal ileum, and then the colorectal involvement is very, very rare. Rectum is usually not involved, whereas the ulcerative colitis is the one which is definitely involving your rectum. And no bacteria is identified in Crohn's disease. These are some different differential features from abdominal tuberculosis. So talking about the gross images of Crohn's disease, the figure number 1 shows the presence of characteristic cobblestone appearance. What is this cobblestone appearance? As you can see, marked by the arrow, there are presence of these mucosal outpouching. So they are linear and serpiginous ulcers, and in between these linear and serpiginous ulcers, there are presence of not involved, the unremarkable mucosa, giving it the appearance of cobblestone. Whereas in case of tuberculosis, you have seen there are presence of transverse ulcers, there are strictures, and then there are fibrosis. The second image is showing you there is presence of this stricture, and you can see the mucosa is completely inflamed in comparison to tuberculosis, where you are just getting fibrosis and transverse ulcers and hypertrophy and involvement of the lymph nodes. Involvement of the lymph nodes will not be here in case of Crohn's disease. So just discussing in brief what are the important points for microscopy of Crohn's disease. We look for two things. First, the features of chronicity, and second, the features of activity. So as the name indicates, the features of chronicity are when there is crypt architectural distortion. So even on small biopsies, we have to look for crypt morphology. If the crypt architectural distortion is there, then you cannot label it as abdominal tuberculosis, because crypts are more or less normal in abdominal tuberculosis cases. And also another feature of chronicity is expansion of lamina propria with basal lymphoplasmacytosis. I again emphasize here, it is basal lymphoplasmacytosis, not just lymphocyte. Presence of plasma cell is mandatory. Now, what are the features of activity? Activity means presence of neutrophils. So neutrophils, once the neutrophils are present within the wall of the crypts, it is called cryptitis. Once they come within the lumen of the crypts, it becomes crypt abscess. And later on, it will break down the crypts, leading to crypt distortion. That is a feature of chronicity. I will be discussing about it in my coming slides. So the granulomas are characteristic, but only present in 50% of cases in Crohn's disease. They are often well formed. How they are different from tubercular granulomas? They are usually well formed, but they are sarcoid like. By sarcoid like, what I mean, they are naked granulomas. The fibroblastic rim is absent in Crohn's disease granulomas. Second, the caseous necrosis is not there. Usually you just see the presence of giant multinucleated giant cells, and that too not Langerhans giant cells. So the important thing here are, so the small biopsies are limited in determining the depth and distribution of the inflammation in case of Crohn's disease. Therefore, diagnosis is often reliant on clinical correlation or examination of the resection specimen. Because in Crohn's disease, you have to look for the skip lesions. And the differentiating features from tuberculosis is the presence of granulomas. The presentation grossly is also different, and microscopically also the granulomas differ in both the conditions. So how the granulomas of Crohn's disease are different from tubercular granulomas. So again, this is from the HE picture is from the terminal ileum. Now you can see marked by the arrow. In the lamina propria, there is this image. These are non-caseating epithelioid cell granuloma within the lamina propria marked by the arrow. Here you can see there is no caseous necrosis. There are no giant cells, just the collection of epithelioid cells. So, and that too, they are also seen only in 40 to 60% of the cases. But the absence of granuloma does not exclude your Crohn's disease. So in that case, if only we are seeing granuloma, no caseous necrosis is there, then we have to keep tuberculosis as our first differential, and second differential would be Crohn's. Again, in figure number 4, you can see there is presence of these granuloma. Mainly, you can see the giant cells, and it is present within the muscularis propria. The figure 3, it is showing within the lamina propria, and it is showing within the muscularis propria, indicating because Crohn's usually have transmural inflammation starting from lamina propria and going till serosa. In figure number 5, you can see non-caseating epithelioid cell granuloma, the hyper image in muscle layer, and all you can see are these multinucleated giant cells only. And how these giant cells are different from Langerhans giant cells? Because as I've told you, the nuclei position is very important. Now the important feature I'm talking about is activity. You have to look for the crypt morphology. Many a times we write in our report, there is presence of crypt abscess, there are presence of crypt architectural distortion. What do we see when we call that? So in figure number 6, you can see there are presence of these multiple crypts. As I have marked by the arrow, there are presence of these neutrophils within the crypt lumen. So numerous neutrophils within the crypt lumen is a diagnostic hallmark. That is, we call it crypt abscess. And as you can see, these neutrophils, they are distorting the crypts. The crypts are of variable size. And this feature is crypt architectural distortion, and this is the feature of chronicity. Now, in figure number 7, you can see again the hyperview of the crypts. As I've marked with the arrow, there are presence of these neutrophils within the crypt epithelium, and that is inflammation of the crypts. When you see the neutrophils within the crypt epithelium, that is nothing, just the inflammation of the crypts, and that is cryptitis. So these are the features of activity. This you see in Crohn's, this you will not see in tuberculosis. Again, as I've told you, the resection specimen is must to label it as Crohn's specimen. This is a colectomy specimen from a patient of Crohn's disease. Now, you can see marked by the arrow, right in the center, the mucosa is normal, whereas it is surrounded by, on both the sides, by ulceration. So on right hand side, on left hand side, the mucosa is denuded and it is replaced by acute granulation tissue. So that indicates that it's a skip lesion because the inflammatory process is not continuous. Second thing, you can see marked by the star, there are presence of these lymphoid aggregates which are there. So the diagnostic features here are the deep ulcers and fissures can be seen in later stages. The transmural inflammation is there and the non-caseating granulomas are there, which are very important in differentiating it from tubercular granulomas. Next slide, please. Many a times we do report chronic non-specific inflammatory pathology. Now, what do we understand by it? Why do we report it like this? When there are no diagnostic features of concerned disease or disorder identified within the biopsy submitted, the small biopsies I'm talking about here. And second, in that scenario, what we do, we usually call up our clinical friend and we correlate clinically that what are the endoscopic findings. And we usually ask for the repeat biopsy from more representative area. Now, and especially on the clinical grounds, if the clinical suspicion is there, then we ask for the repeat biopsy. Then most important, mild chronic inflammatory infiltrate should be there. That is predominantly lymphocytes. It should be there, but there should be absence of plasma cells. So these are the 3 points when we call it chronic non-specific inflammatory pathology, when there are no diagnostic features. And second, we ask for repeat biopsies, morely on the clinical grounds. And when there is just presence of chronic inflammation, no granuloma, no necrosis, no crypt morphology distortion, nothing. And there are no plasma cells, just lymphocytes. Thank you, sir.
Thank you, Dr. Vandana. There are many points you have covered. I think the most important thing we have by your presentation is how to differentiate abdominal tuberculosis from the Crohn's. So I wanted just to ask you, because you talked about biopsy specimen or resected specimen. And sometimes from the lymph node, people do talk about FNAC also. So what is your comment about FNA? If somebody is doing FNA, is it possible to diagnose abdominal tuberculosis from the lymph node?
Sir, usually the FNAC is a inconclusive investigation. The biopsy is definitely diagnostic because in biopsy you get to see more tissues, and most of the times in FNAC the cellularity is not there. So there are some drawbacks of FNACs, and definitely biopsy is having an upper hand over FNAC, sir. Because in biopsy you are seeing much tissues, whereas in FNAC most of the time it is acellular or it is hemorrhagic, or they do not hit the lesion because it is heterogeneous. So that is how, sir, the biopsy is
One message
diagnostic.
is clear that we should have either a biopsy, even if we are doing a needle biopsy.
Yes,
And
sir.
and the second is important message is that we need to have a good chunk of tissue. So just
Yes,
to
sir. Yes, sir.
re-emphasize for the people who are listening, that you said that the hallmark is epithelioid granuloma, which can be differentiated from Crohn's. If it is in Crohn's, it would be transmural, but it is usually not transmural in a case of tuberculosis. And giant cells, Langhans giant cells is usually in tuberculosis, but these typical cells are missing in a Crohn's. And
And sir,
cryptic
cages
short-term.
necrosis.
Yeah. So caseation, you talked about what percent of the people in abdominal tuberculosis we get caseation. I hope it is less common in abdominal tuberculosis. So what percent and then is it very difficult to diagnose tuberculosis in the absence of caseating necrosis?
Sir, like I've told you, in we do receive specimens, but we really work in a holistic manner. We have to ask about the B symptoms, the fever, the evening rise of temperature, and the weight loss, anorexia, all that, and then we do get these in small biopsies also, if there is presence of granuloma, most of the times we do get presence of granulomas, sir, and that too caseating granulomas. So we do differentiate it from Crohn's. And malignancy is entirely different thing, sir.
So I would like other senior people to give their comments,
Yeah,
please.
Chetna,
Yes,
again,
sir.
just an additional point that what Dr. TD was saying that on FNAC, can
Yes,
you
sir.
see caseation necrosis? Can you see Langerhans giant cells? Because
Yes,
many a
sir.
time,
Sir,
yeah,
in FNAC, if the FNAC has been taken from the representative area, we do see caseous necrosis, sir, but the chances of getting Langerhans giant cells are not much.
but
But
sometimes it is possible for you to say on
sometimes,
FNAC that it is tuberculosis.
yes, sir, definitely. And sir, one more important thing I would like to emphasize here. Usually in case of tuberculosis, when the FNAC is done from the cervical lymph node, then it is very much representative. We give it as a tuberculosis, but in mesenteric lymph node involvement, the upper hand is of biopsy, sir.
Yeah, because in the neck, you don't
Yes,
expect
sir.
Crohn's disease to be there.
Yes, sir. Yes, sir. And it is easily done.
Okay, okay. So I think we'll move on. I will introduce the next speaker because she's also from my institution, Dr. Ayushi. She is in the Department of Microbiology, also pursuing her PhD at the same time. And she's going to talk to us about the molecular diagnosis. Ayushi, please. Unmute karo apna. Please unmute and share your screen. Yeah.
Yes, sir. Good evening, everybody. If I could just be allowed to share, because I
Yes.
think I got disconnected somewhere in the middle.
Himanshi,
It says
Dr.
only the host.
No.
It says only the host. All right. Okay.
And as I mentioned earlier, she's abroad, but she has agreed to participate online. Thank you very much. Actually, with all these online activities, it doesn't make any difference whether you are abroad or you are sitting in another room, isn't it?
Absolutely, sir. I'm just not getting the option of sharing screen somehow. It's not being activated for some reason.
Maybe log out and log in again then.
All right.
Sometimes it happens.
Okay.
So in the meantime, those who are watching, this is how you can join Jaipur Surgical Tutorial. Just send a WhatsApp message to Dr. Anand Nagar, who manages JST. That is his number. And for the master class, again, Dr. Anand Nagar. Actually, if you join JST, you will get information about all the master classes also. And this is for the Friday afternoon activity, Jaipur Surgical School. Dr. Kailash Kudia is looking after the participants, and Dr. Peeyush coordinates the faculty program. And if you want to read more about abdominal tuberculosis, as I mentioned yesterday, a lot of my colleagues have co-authored several chapters with me on abdominal tuberculosis. So just send me a mail, vkkapoor.india@gmail.com. And this is information about the 4th Jaipur Surgical Festival, first weekend of December, 6 to 8, complications in surgery. And that's the website.
The only thing I'm not getting is share screen option.
No.
Other than that, I'm getting everything else.
Are you on a phone or a laptop?
So I'm on a phone.
Anybody knows how to do it from the phone?
Now see, because sir has stopped sharing, might be able to share.
Okay.
नहीं, आपका नीचे आइकॉन ही नहीं आ रहा है या आइकॉन पे क्लिक कर रहे हो तो नहीं हो रहा है?
Icon aa raha hai, sir. I'm getting the options of photos, iCloud Drive, Dropbox, OneDrive, SharePoint Drive, Box, website URL, and bookmark. Everything except for share screen.
No, that is how you will share. Where is your file stored in the phone?
It's on the keynote presentation.
So you must be getting the option of keynote.
No.
Or maybe.
तो आप ऐसे ही करो, फिर आप भी पीयूष को भेज दो.
Okay, sir.
चैट में पीयूष का ईमेल एड्रेस है.
Sir, could you please send me the mail ID again?
It is there in the
It's
chat.
not in the, so my chats have
आपने
disappeared.
दूसरे सिस्टम से लॉगिन
हाँ.
किया है, मैं भेज रहा हूँ आपको. Just wait. Yes, भेजा मैंने आपको. Maybe in the meantime, Piyush, you can make your presentation.
Yeah, I'm ready, sir.
हाँ, आप करो. So, as I said yesterday, because Dr. Yadav had asked Dr. Prakash Sasmal about solid organ tuberculosis. So, very recently, Piyush and me, we have done a review of HPB tuberculosis, which is going to be published in the Turkish Journal of Surgery. So, I requested Piyush to make a small presentation on HPB tuberculosis. And then we will have Ayushi's presentation. Yes.
Oh, my slides are visible, sir.
Yes.
Okay. Good evening to all. So I'll be presenting the indications of surgery in abdominal tuberculosis. Although in this part also I have covered a little bit about solid organ tuberculosis, but separately also, if the time permits, we'll discuss about solid organ tuberculosis. So I'll just give a brief introduction as already has been dealt with. And what are the different forms of abdominal tuberculosis and what is the role of surgery in these forms and what are the most common types of surgeries performed?
Sorry, Piyush, मैं कह रहा था कि आप HPB वाला कर दो, because surgery हम medical treatment के बाद करेंगे.
Okay, sir, I'll
just make a small presentation about HPB tuberculosis. Okay. Yeah.
So now I'll just switch to HPB tuberculosis. So, like it is abdominal tuberculosis is also rare. So, HPB tuberculosis or solid organ tuberculosis is also rare, and it compromises around 1 to 2% cases of the abdominal tuberculosis. Like abdominal tuberculosis itself is 15 to 20% cases of all extrapulmonary tuberculosis, and in those 15 to 20%, 1 to 2% is HPB tuberculosis. And as obvious, the literature is very sparse and there are very few case series. Highest case series is reported from India of around 38 cases. And unlike other cases of abdominal tuberculosis, it is very difficult to diagnose this form of tuberculosis. And I'll subsequently tell you why. So it has been divided into the primary organ or associated lymph nodes like any other abdominal tuberculosis, liver, pancreas, and biliary tract, and then adjacent SGL lymph nodes. So liver and biliary tracts are commonly involved, but the pancreas involvement is very rare among these solid organ. The reason is because of the resistance provided by the pancreatic enzymes like lipases and deoxyribonucleases. So the route of the spread, it can be via arterial or portal venous system. So if there is any other organ is involved like lungs, so the bacteria can travel to the hepatic artery and then lodge into the biliary system as well as into the liver. Or if they are swallowed into the sputum, they can access to the mesenteric system and then gain access to the portal venous system and reach the liver. Intestinal ulcers may heal in the intervening time and they only manifest as a HPB tuberculosis. So the clinical presentation is pain followed by jaundice, pruritus, gastric obstruction. Depends upon what the organ is involved. And constitutional symptoms like B symptoms, fever, anorexia are present only in 30 to 35 cases. And coexisting pulmonary tuberculosis that can hint to the diagnosis is present in around 6 to 38% of the cases. It closely mimics malignancy. That's why it's very difficult to diagnose these cases preoperatively. Just coming on to the specific type, liver, it is the most common type among the HPB TB. And the symptoms are abdominal pain followed by fever, hepatomegaly, jaundice, and sometimes splenomegaly and ascites. In the biliary system, biliary tree is the most commonly involved, followed by the hilar lymph node and followed by the gallbladder. Isolated gallbladder involvement is also rare. Biliary tuberculosis may manifest as jaundice, pain, and weight loss. And there may be involvement of IHBRs by tubercular granulomas, which may result in complex strictures and may mimic either intrahepatic cholangio or a primary sclerosing cholangitis. Pancreas, as I said, it's very rare to reach pancreas because of the enzymatic activities. If the pancreas is involved, and again, it can be a mass forming, which may resemble malignancy or maybe an abscess in around 10% of the cases. And similar to malignancies, the symptoms are also similar, like pain and obstructive jaundice. And there may be presentations which may include like acute or chronic pancreatitis, hemorrhage, secondary to the splenic venous thrombosis. And 50 to 70% of the pancreatic tuberculosis seen in age less than 30 years. So for the diagnosis, clinical history, endemicity, and also the past history of pulmonary tuberculosis is important with high index of suspicion. It's the high index of suspicion along with the endemicity and other clinical factors which may help in reaching the diagnosis along with other diagnostic tests. So these routine tests for tuberculosis like Mantox, CRP, ESR, and chest X-ray may aid in the diagnosis of HPB tuberculosis, but are certainly not diagnostic. And also there are many false negatives and not much reliable in case of HPB tuberculosis. Specific tests coming on to the imaging like CECT and MRI and endoscopic ultrasound, these are commonly performed, but again, the problem is that these findings may mimic malignancy. Like in liver TB, miliary form is the most common through the arterial spread, and there may be micro abscesses. And if it is in the healing phase, there may be calcification in these abscesses. And on the CT, they may appear as a low density nodules like tuberculars, and they may mimic diffuse metastasis also. And if they gain through portal vein, they may appear as a large granuloma near the portal triad. Pancreatic TB may appear as a focal mass with mixed cystic attenuation with thin rim of peripancreatic enhancement and lymphadenopathy. Solid parenchymal lesions are rare, but 2/3 may be multifocal and remaining 1/3. 2/3 are solitary and remaining 1/3 are multifocal. Calcification may be seen in around 70%. And like malignancy, vascular invasion may also be seen in 1/3 of cases. Similarly, in biliary tuberculosis, if isolated gallbladder involvement is there, it may mimic a thick walled GB or a xanthogranulomatous cholecystitis. There may be pruning of distal intrahepatic ducts, tight hilar strictures, long smooth strictures that may closely resemble the malignancy. And EUS may aid with along with CT. Not to mention that MRI as well as PET scan has been done for the diagnosis of HPB tuberculosis, but as we know, the sensitivity is far less and often subjected and clinician always depends upon either image guided biopsy or FNAC from the representative sites. So if we are able to obtain a biopsy or FNAC from the representative site, it is subjected to both microbiological as well as histopathological examination. On microbiological examination, AFB can be seen in around 0 to 60%, and on culture, the sensitivity is only 10%. And histopathology, like already been discussed, if we're able to show the Langerhans giant cells, we can diagnose, but the sensitivity is low, ranging from 14 to 100%. Other tests like nucleic acid amplification tests like TB Gold, quantiferon, and CBNet are used with very sensitivity, but these have high specificity as compared to microbiological and histopathological examination. Role of surgery is mainly for the diagnosis purpose, because most of the cases are diagnosed post-operatively, and the surgeries, because they resemble malignancy, though the spectrum may extend from a simple cholecystectomy to more complex resections like pancreatorrhinectomy and extended liver resections. But the outcome, it has been shown in literature that in terms of morbidity and post-operative outcome is better when it's compared to the malignancy. And often, in case of biliary tuberculosis, if the patient somehow the diagnosis is made preoperatively and started on anti-tubercular treatment, there may be a fibrotic reactions that may increase the jaundice due to worsening of the tight hilar strictures. So that may also form an indication of surgery. Just to summarize, that HPB tuberculosis is rare, And it is almost impossible to make a preoperative diagnosis of HPB tuberculosis. And most of the diagnosis made post-operative based on the specimen biopsy. And these may mimic malignancy so closely, and that is why the surgical interventions are required frequently. High index of suspicion is necessary, and good diagnostic modalities are needed. And lastly, the coincidence of hepatobiliary tuberculosis and HIV must be actively searched for in all the cases. Thank you.
So thank you, Peeyush. Are we going for discussion, sir? Or we have because
no, I think we will proceed with Ayushi's presentation.
Yes.
Just I'll download it, sir.
Yes, sir.
I mean, as Peeyush said, it will be very, very rare occasion that we will either suspect or make a diagnosis of HPB tuberculosis. Most of the times it comes as a histological surprise when you have handled it like malignancy. The only situation where you would think of tuberculosis is a young patient who looks like malignancy, but because of the age, you think it could be something else. So this is where you think of tuberculosis or lymphoma. Ayushi, please.
Good evening, sir. Today I'll be talking about the molecular diagnosis of abdominal tuberculosis. Let's start with the sample collection. So I've included very standard pictures of National Tuberculosis Elimination Program, the sample that they suggest in the GI sample. It's tissue pus peritoneal fluid or the biopsies or this fluid, and the optimum quantity for a sample is required to be 5 to 10 ml. Next, please, sir. So when we do talk about abdominal tuberculosis, depending on the type of abdominal tuberculosis, if it could be peritoneal, gastrointestinal, perianal, or pancreatic hepatobiliary, the sample differs. For peritoneal, the suggestive sample is a cytic tap, and for every other, the suggested sample is endoscopic guided biopsies, which will be processed microbiologically. Next, please, sir. This is the chart of pediatric abdominal tuberculosis. If it presents as ascites or enlarged abdominal lymphadenopathy or intestinal involvement, the sample size, the sample required is mentioned. Next, please, sir. This is the diagnostic algorithm if abdominal TB suspected. Separate samples are sent for separate purposes, and we'll just talk about the molecular aspect of it. Next, please, sir. So when we do talk about the diagnostic modalities, our story starts with a microbiological examination. The most routinely done test is the acid-fast bacilli staining, or the Zellin staining, that utilizes the presence of mycolic acid in the cell wall of MTB, which can hold the carbonyl fuchsia color inside of the cell wall. The gold standard till date is the culture. Earlier, solid culture was used, which was the LJ media. Today, we've moved on to radiometric advancements like BACTEC 460 and GIT BACTEC 960 and EPES2 system. The advantages of which are that it does not contain any radioactive substance, it does not require a CO2 incubator, and there's a minimal risk of contamination. But the disadvantage is the sensitivity does not greatly differ from the conventional LG media. Moving on to the molecular diagnostics. The most common question that I get asked is if the sample should be sent for GeneXpert or CBNAT. So CBNAT is the basic principle. It's cartridge-based nucleic acid amplification technique. There are various instruments available by which CBNAT can be tested or used. The most common is GeneXpert, and what NTEP, what falls under government, is TrueNAT. Both of them are semi-automated. GeneXpert is cartridge-based, while TrueNAT is chip-based real-time PCR technique. The second generation of both have been introduced. For GeneXpert, it's Expert MTB RIF Ultra, and for TrueNAT, it is TrueNAT MTB Plus. GeneXpert only targets the rifampicin resistance gene, RPOB gene. So it's a single-step procedure. it will detect MTB along with the rifampicin resistance gene. But for TrueNAT, it's a two-step procedure. First, it will target the IS6110 and the NRDB gene. And in the second step, in the second chip, it will detect the rifampicin resistance. When we talk about polymerase chain reaction, so CVNAT uses the step of polymerase chain reaction, but only TrueNAT will tell you what is the real-time analysis of the PCR reaction. The basic principle of PCR is using the ability of DNA polymerase to synthesize the new strand of DNA complementary to the predefined template strand. When we talk about the conventional PCR, it targets IS6110 gene. It is specific gene segment of M. tuberculosis bacteria that is not found in non-tubercular mycobacteria, owing to which it offers low sensitivity. Suppose if the sample is taken too little or it is taken too deep, so the amount of extracted MTB DNA might not be much, and it could give a false negative result. It only detects the IS6110 gene sequence, so that if bacteria is in an imperfect condition, it will not be diagnosed, so it won't be identified in the PCR reaction, and again, it will give a false negative result. Next slide, please, sir. To overcome that, we are using multiplex nested RT-PCR reactions. Owing to the increased number of inhibitors in extrapulmonary tuberculosis, such as GI tuberculosis, one-step nested PCR primer probe contains two pair of primers for each target sequence that is specific to M. tuberculosis complex. The outer part of primer hybridized with a conserved sequence specific to MTB at a higher melting temperature. Therefore, the specificity of the reaction increases. And the second pair of primer, it hybridizes at a lower melting temperature. So the sensitivity is increased several fold. To put it plainly, there are two sets. The first set covers the outer region of the sequence, so it can be identified in one go. And the second set of primer applies to the only conserved portion of the gene, so the sensitivity and the specificity both increase several fold in one reaction. And it will give you, if there's a very little amount of DNA present in the sample, it will give you the result. So that's what we've been using these days, the multiplex nested PCR. When we talk about line probe assay, it is a rapid test for drug resistance. The methodology is reverse hybridization of amplified products on nitrocellulose membrane, targeting probes specific to the detection of MTB and the mutations associated with the drug resistance. There are two line probe assays available. First is the first line probe assay, which targets rifampicin and the CATG and INH-A promoter range for isoniazid. The second line probe assay identifies resistance in the fluoroquinolone genes and the aminoglycosides and cyclic peptides. Then we have the interferon gamma release assay. That is your TB Gold, your quantiferon. So earlier we used to go for tuberculin skin test. Now that is being substituted by IGRA. Most commonly, we use TB Gold or quantiferon, but the only drawback is it does not identify recent infection. It will only identify latent TB infection. It is not used to diagnose an active TB infection because basically it uses the interferon gamma release assay. It has two international commercial kits, quantiferon and TB Gold, T-Spot. Quantiferon reads the concentration of interferon gamma via enzyme-linked immunosorbate assay, while T-Spot reads the number of IFN gene secreting T cells via an enzyme-linked immunochromatographic assay, immunospot assay. All the serological tests have been banned by the government of India in 2012. So there's no kit that identifies any serological diagnosis of TB. That is not allowed anymore. When we talk about sequencing, sequencing is not done for identification or patient diagnosis per se. because the methodology is too long, it takes a very long time to process one run, and it is done only on cultured specimens. So we'll have to culture the TB bacteria first and then run sequencing on it. It is not for patient management, but for disease surveillance or outbreak investigation or transmission analysis or infection hotspots. There are 3 generations of sequencing. The first generation was the original Sanger sequencing. The second generation was pyro sequencing in Illumina and your Iron Torrent. And the third generation that we're using currently is the Oxford Nanopore sequencing. Because the whole genome sequences takes a very long time, now we've moved on to targeted sequencing. Next slide, please. These are the various sequencing methodologies that have been used so far. So as an alternate approach to whole genome sequencing, for obtaining a comprehensive resistance profile is the design of rapid targeted genomic panel that includes only genes known to be involved in the drug resistance. It is relatively less costly than whole genome sequencing. And because we have to mainly identify resistance mutations that can be there in the sample, so we can curate a very specific panel to all the genes that are responsible for mutation and run a targeted sequencing on it. But again, it's not for patient management. It is just used for disease surveillance or outbreaks or hotspot identifications. So to summarize, the sensitivity, while the sensitivity and the specificity of RT-PCR or a PCR reaction is far more than AFB or culture techniques, there are still drawbacks to it. It won't identify the difference between the live bacteria or the dead bacteria. So it's not used to diagnose active infection or patient follow-up. It is not used for. It will identify the infection, but it won't identify if the treatment is taking effect or not, because it will recognize and give results for dead DNA also. So for that purpose, culture is still the gold standard for MTB diagnosis. And that's just about it. Thank you.
So thank you, Dr. Ayushi. And you have covered a little bit of difficult topic for the surgeons. And now it is in our institutes also, it's very frequently used. Our colleague in the Department of Gastroenterology, they did some stool PCR with the help of Delhi, and they have found that there was a total article, I don't remember, but it was discussed many times, and they found that even in a patient where there is no positivity clinically, and about 76, I hope about close to 70% positivity was found, and they even the node positive patients had I think maximum sensitivity. Then second was lumen or intestinal. This is what is. So you have any idea about stool PCR, because it is little bit easier to do, if I think, to my mind.
Yes, sir. It is not diagnostically proven, but in pediatric age group where it's difficult for the clinicians to get sample, it is sometimes recommended stool samples be tested for TB. But again, there are too many inhibitors in a stool sample, so it's very difficult to isolate DNA. And if we do, because the gene sequence could be too fragmented for it to be completely correctly identified. And it could also give you a false positive if there could be no infection, and it could still give you a false positive reaction. So it's not recommended, but sure, it can be used.
And
sorry.
Yes, sir, please.
Is our molecular tests helpful in patients with resistant tuberculosis when we want to see the resistance pattern and sensitivity?
So as of now, under National Tuberculosis Elimination Program, TrueNAT is being done free of cost. So every sample that is being sent for MTB DNA detection, if it is positive, it will be run for rifampicin resistance. If rifampicin resistance is noted, it is parallel to isoniazid. It is considered as first-line drug-resistant strain. So it's very helpful. But PCR takes a little while longer and it's more costlier. So my recommendation would be for CBNAT, where it could be identified. And then if we do have to go for a second line drug resistance, we can go for line probe assays, which will identify a second line, your fluoroquinolones and aminoglycosides and peptide cyclopeptides, sorry.
Maybe Mohit can cover it at the end of his presentation, that if you are suspecting drug resistance or if the patient is not responding, then how to use these tests to guide your treatment.
Yes, sir. Yes, sir.
So with that, now I will introduce the next speaker, which is Dr. Mohit Agarwal. He is my colleague in Pulmonary Medicine Department at the Mahatma Gandhi Medical College and Hospital. And he is going to teach us about the medical management, ATT and steroids. Mohit, please.
Thank you, sir.
TD, you wanted to say something before we move on?
No, sir. Yes.
So first of all, thank you, sir, for making me
Make
read
it full screen if possible.
Sorry, sir.
Full screen कर दो.
Sir, full screen है सर यहाँ पे.
हाँ, तो कुछ प्रॉब्लम है, वो हम लोगों को नहीं दिख रहा है. चलो
Slide show mode. Go to slide show mode. Slide show.
ऊपर स्लाइड शो पे क्लिक करके.
हाँ.
एंड रिज्यूम स्लाइड शो.
हाँ.
नहीं हो रहा है. हाँ, वो इट हैपेंस समटाइम्स कि आपके स्क्रीन में हो गया और हमारे में नहीं हुआ. Let's hope that the slides move.
Okay, sir. I already shared my PPT on Dr. Varshney's mail ID.
चलो आप एक बार मूव करो स्लाइड. आपका देखें मूव कर रहा है या नहीं. नहीं कर रहा है. No, there is some
स्लाइड को मूव करने के लिए सर हिज कर्सर हैज टू गो टू ईच एंड एवरी स्लाइड, देन इट विल मूव. अगर हमारा स्लाइड शो पे नहीं है तो कर्सर को उस पे क्लिक करना पड़ेगा ऑन एवरी स्लाइड.
यस, नाउ इट इज मूविंग. ऐसे करके कर लो. इट विल बी इजियर फॉर यू. यस.
Okay, sir. So first of all, thank you for making me read abdominal tuberculosis in depth. As you already told me, I am a pulmonary physician, so I am more focused towards the pulmonary tuberculosis. So just because of you, I read the abdominal tuberculosis since last 3 days, and I will try to recover maximum part on this. So in today's lecture, we will discuss the duration of the anti-tubercle therapy, the classification of abdominal tuberculosis, why it is necessary, when to give anti-tubercular therapy, before food or after the food, when to increase the duration of the ATT, and what are the risk factors for abdominal tuberculosis. So as we, sir, my slide is moving.
Yes.
So why the classification of abdominal tuberculosis is necessary? Because it not only decide the duration of anti-tubercular therapy, but also decide when to follow up the patient and which investigation you have to do on the follow-up. So already there is a lot of discussion on the clinical presentation, radiological presentation, microbiological presentation, diagnosis, histopathological diagnosis, or endoscopic diagnosis. So it's part to cover the management part. So we divide the cases into three forms. Presumptive case means there is diagnosis of the abdominal tuberculosis just on the clinical basis. We don't have any microbiological evidence or histopathological evidence. Second, there is a probable case in which there is histology, in which we see the granuloma without caseation or chronic inflammation with clinical, endoscopic or radiological finding. And third case is the confirmed case, which we have typical histology with caseations with granuloma, and there is confirmed microbiological findings from the tissue. This is very necessary to classify the patient on findings, because the chances of recurrence is more in presumptive case or probable case. The treatment failure is more in presumptive case, and increase the duration of the ATT is more in probable or presumptive case. So whenever we prescribe anti-tubercular therapy, we need to classify the patient, and with the positive findings, why we start the ATT, either we have started ATT in the presumptive case or probable case, or it's a microbiological confirmed case. So the most common question comes to us by the gastroenterologist, by the surgeon, कि सर कौन सी ATT अच्छी है, either it is government approved ATT or private ATT, or either it is a fixed drug combination therapy or single drug formulation therapy. So there is no difference between the government ATT or the private ATT, and not a difference between we have to fixed drug combination is better or single drug formulation is better. Second, how much amount of the ATT we have to use. So now the government has started in 2 packs, which is intensive phase and continuing phase. In intensive phase, the fixed drug formulation is come in the red packet, as we see in the previous slide, this one, and the CP phase comes in the green packet. And number of the tablets depends on the weight of the patient. As you can see on the screen, 25, we are talking about the FDC in the adult part. So if the patient's weight is 25 to 34 kg, he has to take 2 tablets of the fixed dose combination. If it is greater than 75, he has to take the 6 tablet of the fixed dose combination. Initially, it was believed we can prescribe maximum 600 mg of the rifampicin or 300 mg of the isoniazid or 1500 mg of the pyrazinamide and 1200 mg of the ethambutol. Now the concept is totally changed, and it is approved by the Ministry of Health and Family Welfare and the IMR Institute of Research also. So we can prescribe a maximum isoniazid of 450 mg, 900 mg of rifampicin, 2400 mg of pyrazinamide, and 650 mg of the ethambutol. It depends if the weight is greater than 75. So I'm talking about the maximum dose. So initially it was 600 mg in rifampicin, but right now we can give up to 900 mg of the rifampicin, because it's a commonly mistake done by the surgeon and the gastroenterologist. They just prescribe rifampicin of 600 mg if the patient weight is still 70 kgs or 80 kgs. So the amount of the drug is very important, and the combination of the drug is very important. So if we see the data, either fixed drug combination is better or the single drug formulation is better. So there is a Cochrane database study published in 2016 in which they clearly says the fixed dose combination and single drug formulation have similar effect for treating people with newly diagnosed pulmonary tuberculosis. Second study, which is published in the BMC Infectious Disease in 2017, in which they says single treatment group had higher visual side effects as compared to fixed dose combinations. Fixed dose combination may be more effective in diabetic patients. However, further studies are required to confirm such findings. Then again, there is a study which is published in the Egyptian Journal of Bronchology, in which they says single drug formulation is recommended in the patients with borderline liver function, GI troubleness, and presence of the extensive radiological infiltrates. Another study is published in 2018 in the Current Pharmacological Reports, in which they says single drug therapy tolerance was characterized by higher frequency of paresthesia, retrobulbar neuritis, nausea and vomiting than fixed dose combinations. And the recently published in 2003 in BMJ Open Respiratory Research, in which they says there is no evidence of drug resistance or TB recurrence if we are using the fixed drugs combination. Now why should I quote these studies? Because maximum prescription we have seen, either they are taking the private ATT or they are taking in the single drug formulations. So the advantage of the government fixed dose combination is, first, the patient gets benefited not only by pharmacological drug therapy, but he will get some amount of the rupees from the government. Second thing, the cost of the ATT around comes 1500 to 2000 bucks per month. And in our in the endemic area in India, we have seen a lot of the poor patients. So 1500 to 2000 rupees are still valuable for them. So I will prefer fixed drug combinations until unless it is contraindicated. And what are the contraindications we will see in this lecture. Second question, patient asked to us कि सर ये जो थेरेपी है, ये जो टीबी की दवा है, हमें खाना खाने से पहले लेनी चाहिए कि खाना खाने के बाद लेनी चाहिए? तो my answer is whenever possible, counsel the patient. You have to take these medication before breakfast. Before breakfast, and take the drug slowly in the interval of the 15 to 20 minutes. No need to hurry to take all the pills together. You have to take one pill, then you have to wait for 2 minutes, then you take second pill, third pill, and fourth pill. Why I'm saying that? Because just because of the pharmacology, if all the drugs we are taking together, the area under curve of these medication is got maximized, and it will give maximum response to the patients. So this is the studies published in Indian Journal of Respiratory Medicine in 2017, in which they clearly show food significantly reduce the plasma concentration of the first line anti-tuberculosis drug therapy. So whenever possible, try to counsel your patient, give anti-tuberculosis therapy before food, even before breakfast. Not only in India, even Heartland National TB Center, situated in the Houston, USA, they also says for isoniazid, take 1 hour before or 2 hours after the meal, but 1 hour before, that's the priority. Rifampicin, same, take 1 hour before. Ethambutol, you can maybe taken with the food. For levoflox, take 2 hours before, and for pyrazinamide, may be taken with the food. So whenever possible, counsel the patient, take the ATT before the breakfast or before the meal. The third question, what is the duration of anti-tubercle therapy in abdominal tuberculosis? So as already I told you, we need to classify the patient, which type of abdominal tuberculosis patient has. Either it is hepatobiliary tuberculosis, or it's intestinal tuberculosis, it's a peritoneal tuberculosis, it's a pancreatic tuberculosis, because the duration is also depend. So there is a clear-cut guidelines for hepatobiliary tuberculosis. We can extend the treatment for 9 months. But other form of the tuberculosis, we have to give the duration of the 6 months, and we can increase the duration on case-to-case basis. We need to consider risk factors also before starting the anti-tubercular therapy on follow-up of the patients, because these are the risk factors which makes the chances of the relapse or recurrence of the tuberculosis very easily, failure of the treatment very easily, because the patient has some risk factors like cirrhosis, chronic kidney disease. These patients are comes in the risk group, because they are very prone for relapse of the tuberculosis, not because of their comorbidity, but just because of the drug interaction also, because they are taking multiple pills. If they are taking multiple pills together with anti-tubercular therapy, there are more chances of the drug interaction, more chances of the side effects. And these patients are least adherent for the anti-tubercular therapy. So we need to identify what are the risk factors are associated with the if the patient is recently diagnosed with the HIV, we need to start HIV treatment after the 14 days of the treatment. If the patient has type 2 diabetes mellitus, we need to control the blood sugar also. If the patient has prior history of the pulmonary tuberculosis, we need to find out the patient is still there is active lesion or not, is there or not. If the patient is using steroids, or the patient has underlying malignancy, or the patient has some liver disorders or chronic kidney disorders, because these are the patient in which we need to increase the duration of the ATT, and we need to find out the drug interaction, either patient is taking which drugs. And rifampicin, especially rifampicin, he's responsible for he's an enzyme inducer by pharmacology. So if there is patient is taking warfarin or patient is taking other drugs, so rifampicin is most commonly drug which can cause the failure of the other drugs. So we need to find out the risk factors along with the abdominal tuberculosis. Second, what is the recommended dose for the patient with chronic kidney disease? As I already explained, because these patients require more duration of the therapy, modification of the therapy also. Rifampicin, it is metabolized by the liver. So there is no need to adjustment in the dose in the patient of the chronic kidney disease patients. Same as with isoniazid, it is metabolized by the liver. But the pyrazinamide and ethambutol, they are excreted by the kidney. So we need to modify the dose of the pyrazinamide and ethambutol. We are not supposed to give these drugs daily. We have to give alternate day, if possible, after the dialysis. So we need to identify risk factor. Patient has CKD or not. If CKD is there, we need to modify. Same thing happened with the patients who are having chronic liver disease. All the ATTs, specifically isoniazid, rifampicin, and pyrazinamide, they are very hepatotoxic. So patient who is already having chronic liver disease, we have to be very cautious. First of all, we need to classify the patient into according to child group, child score. Either patient's fit is into child A group, child B group, or child C group. If the patient comes in child A group, we have to give the regimen in which 2 hepatotoxic drugs should be there instead of 3. And the treatment recommendation is the duration of the antitubercular therapy is 9 months. Or if we are giving with 4 drug regimen, we have to omit the pyrazinamide because it is the most hepatotoxic drug. It is replaced by the streptomycin or levofloxacin in intensive phase and 6 months of HRE phase. Or we have to start the regimen with RZE. We have to omit the isoniazid and give the treatment for 6 to 9 months. Similarly, in child B and child C group, we have to modify the drug regimen. Now the question comes, indication of the steroid in tuberculosis. So the steroid is indicated in tuberculous meningitis, ocular tuberculosis, pericardial tuberculosis, and adrenal tuberculosis. But there is a strong no to give steroid in abdominal tuberculosis. This is the study published. This is the published in Indian Journal of Gastroenterology in February 2023, in which they clearly says that the research query was, what is the role of adjunctive steroid for treating tubercular peritonitis? So there is one studies which say there is some role of the steroid in anti-tubercular therapy, especially in peritoneal tuberculosis. But the quality of the study was so poor and it was limited generalizability. So the recommendation is steroids should not be routinely used in abdominal tuberculosis. And second thing, the duration, regarding the duration, what is the duration for ATT must be used to achieve clinical cure? Only one RCT was included, in which they says the combination of trial, 6 months of the therapy is adequate. And it basis on the basis of the case to case, we can extend the treatment also. Then what is the role of steroid and anti-tubercular therapy? Apart from the therapeutic option, it can be used as a therapeutic option for differentiating between intestinal tuberculosis or Crohn's disease. Because we have seen all the lectures, there is a lot of confusion histologically, endoscopically, clinical presentation, intestinal tuberculosis and Crohn's disease, because Crohn's disease is the strong mimic of intestinal tuberculosis. So what we have to do, we have to start anti-tubercular therapy first. If we have no idea on histopathology or there is no microbiological evidence of the pathological evidence of the intestinal tuberculosis, we have to see the patient. If there is no worsening or no change at the 8 to 12 weeks of the ATT, we have to repeat the colonoscopy and do the biopsy. If the patient has clinical response at 3 months, we should monitor and continue the ATT. Then we will look for the new onset worsening or there is no further improvement. Then we will go for the repeat colonoscopy or biopsy. If clinical response is there, so we will, at the 6 months of therapy, we should continue the therapy. We will go for the colonoscopy to see there is the healing or not in case of the intestinal tuberculosis. If there is no healing, then we have to consider the Crohn's disease or multi-drug resistant tuberculosis. Now the question comes, when to follow the patients when you started the patients. If the patient comes in the definitive abdominal tuberculosis or clinically diagnosed abdominal tuberculosis, we have to start the ATT, 2 months of the intensive phase and 4 months of the continuation phase. We have to do clinical assessment at 1 week, at the 4th week and 8 weeks. We will ask the patient either there is any fever or pain in the abdomen, there is disappearance of the abdominal distension is there or not, weight gain is there or not, Second, we have to assess the ATT-induced hepatotoxicity with serial liver function test. If there is the improvement, we have to complete the ATT. If there is no improvement at the 8 weeks, we have to exclude the multi-drug resistant. Second, we have to think about the alternative diagnosis. If there is improvement in clinical diagnostic case, then we have to complete the ATT. The same thing is published in the Indian Journal of Gastroenterology in 2023, in which they clearly says we have to follow the patient in 4 to 8 weeks for peritoneal tuberculosis by doing the abdominal ultrasound. If the patient has intestinal tuberculosis, we have to consider the colonoscopy at 2 months for seeing the early mucosal response. So the clinical parts of the take-home message from this discussion is we have to prefer the fixed dose combination, if possible government added, according to the weight band over single dose formulation until unless contraindicated. It is contraindicated in CLD and CKD patients. Second, drugs to be given without food, preferably before breakfast. Third, we have to duration of the treatment must be 6 months, with the decision to extend the treatment made on case-to-case basis. And the fourth, we have to very close follow-up and monitor for the adverse event is induced by the anti-tubercular therapy. Thank you, sir.
Thank you, Mohit. Thank you. I think since we are already at 8:30, TD, I think we will move on with Peeyush's presentation.
Yes, sir. I think so, but because this presentation was very clear also, so
Yes,
I
yes.
we can move to yes.
Yes, sir.
Sir Peeyush, you can go to your remaining
Mohit,
presentation.
please
Stop कर रहा हूँ
share.
सर मैं. Okay,
Yes.
sir.
Yes, sir. I just...
So Dr. Peeyush Varshney is a former fellow from SCPGI Lucknow. He's currently assistant professor of GI surgery and liver transplant at All India Institute of Medical Sciences in Jaipur.
My slides are visible, sir?
Yes, yes. Slides are visible, Peeyush. You can start.
So, my talk is the last talk, so I'll try to finish it in time so that we have time for discussion. So, briefly, just to give an idea what I'll be talking, a brief introduction of one slide, and then what are the different forms of abdominal tuberculosis and when is the surgery required in each form, and what are the more common types of surgery which are being performed for abdominal tuberculosis. So, extrapulmonary tuberculosis is around 40 to 50% of all cases of tuberculosis, and abdominal TB is the fourth most common variant of extrapulmonary tuberculosis. 1/3 of the patient at presentation or at the time of diagnosis have a disseminated disease, and surgery is indicated only for 15% of cases which are having complications like in the form of perforation, obstruction, bleeding, etc. So 20 to 40% of patients require emergency surgery, and we'll discuss how. So there are various forms of tuberculosis like lymph node, peritoneal, gastrointestinal, visceral, solid organ, and commonly these forms overlap. It's very rare to see a isolated tuberculosis of one particular organ in abdomen and the other is not involved. So these are mainly overlapping form. So broadly, these can be divided into a diagnostic indication for surgery, then a therapeutic may be elective or emergency, and finally the histological surprise that we already discussed mainly in the solid organ TB when there is difficulty in making a preoperative diagnosis. And rightly said that surgery in abdominal TB depends upon the indication as well as the form of tuberculosis. So first is the tubercular lymphadenopathy. It is the most common manifestation, and more commonly the mesenteric, omental, and portal HDL lymph nodes and celiac lymph nodes are involved. And they may mimic malignancy as already discussed and can be an isolated manifestation, but it's rare. So where comes the role of surgery? Most of these lymph nodes can be diagnosed on CCT on the basis of characteristic CT findings and may be targeted on image-guided sampling by the use of ultrasound guidance, CT guidance, or nowadays on the basis of EUS guidance. But there are certain cases which may not be targeted or the sample is inadequate and there is a high suspicion of tuberculosis, which may need to perform a surgery for a lymph node sampling. So surgery is limited to those cases which are difficult to sample by non-invasive methods and or rarely in case where there is a nodal rupture with secondary infection and peritonitis. So this example, like these cases, lymph node to tubercular lymph nodes are difficult to target and sometimes may require a surgery for sampling these. Second is the peritoneal tuberculosis. This is the most commonly following the reactivation of a latent tubercular foci in the peritoneum established via hematogenous spread mainly from the lungs and less commonly from the transmural spread from the infected small intestine. And visceral and parietal peritoneum both may be involved with tubercles and it may lead to exudative ascites and it may be found in 10 to 25% of the cases. So it has been divided into wet ascitic type, fixed fibrotic type, and dry plastic type. I'll not go into details that has already been discussed in the previous lectures. So where comes the role of surgery? In ultrasound guidance or CT guidance, the setting of the demonstrable ascites, lymph nodes, or thickening of mesentery, omentum, these can be targeted. Ascites can be sampled and can be looked for straw-colored ascites with leukocyte count of 150 to 4,000 cells per cubic millimeter and with relative lymphocytic pleocytosis and typically have a low SAG value of less than 1.1. If the ascitic fluid is non-diagnostic and the clinical suspicion of peritoneal tuberculosis is high, then a peritoneal biopsy is usually indicated in the form of a diagnostic laparoscopy. Blind biopsy usually have a low success rate. So in a systemic review, including 402 patients, the sensitivity and specificity was 93% and 98% in making the diagnosis of peritoneal tuberculosis. So at the time of laparoscopy, the findings may be thickened peritoneum with yellow to white lesions, with or without adhesions, and fibroadhesive patterns. This is one of the most common pictures which may see at the time of putting a scope in the form of diagnostic laparoscopy. Other findings may be a violin string, fibrinous strand, or omental thickening, and surgery is also indicated in subset of patients of peritoneal TB presenting with acute abdomen due to tubercular peritonitis. In that case, only lavage is done and biopsy needs to be performed with peritoneal tolerating and the abdomen is closed usually without a drain because the ascites will keep on forming and it will keep on coming from the drain. So usually drain is not placed, or if drain is placed, a very thin board drain is placed till the wound is healed and then it can be removed once the wound is healed. Solid organ TB already discussed. I will just skip the slides. Next is the esophageal TB and the luminal TB, basically the esophageal and the gastric or gastroduodenal TB. These occurs rarely and they spread from the adjacent tissues and usually involve the middle 1/3 of the tuberculosis. In the stomach and duodenum, it is also a rare site of involvement and it is also secondary to the pulmonary tuberculosis. And it may lead to the symptoms of gastric obstruction and obstructive jaundice. Then comes the luminal part, the TB of small and large intestine. It is the most common form and it has been divided into 4 types, mainly ulcerative, hypertrophic, ulcero-hypertrophic, and fibrous. So this will have an effect of surgery that what kind of surgery is needed. And lastly, the rectal or anal TB may present in the form of multiple fistulae, which may require surgery for the treatment. So now coming on to the surgical treatment, what are the most commonly performed surgeries and what are the indications? So first is for the symptomatic abdominal tuberculosis, the emergency indications like obstruction, perforation, and bleeding, in which we have no other options but to go in and do an emergency laparotomy. Second is the persistent symptoms for ileocecal mass, or there may be some partial stricture or in the form of cocoon abdomen. And finally, in the fistulizing intestinal tuberculosis. And diagnostic dilemmas like for diagnosing the peritoneal tuberculosis or where we have a confusion or diagnosis between the Crohn's disease and tuberculosis in which we need to resect the bowel. So there are 3 types of mainly bowel surgeries which are being advocated. First is the bypass. So in the bypass, whenever there are dense adhesions and we are not able to resect that segment, then a bypass may be performed between the two segments which are freely available, bypassing the strictures or the involved segment. But the complications are that it may be complicated by a blind lobe syndrome or a fistula formation, and there may be a recurrent disease in the remaining segments. So it is not routinely performed, just performed as a bailout procedure. Second is the radical or segmental resection. So mostly the segmental resection is performed. It is to eradicate the disease completely, and it is feasible with the advent of effective ATT. But it is hindered by the malnourished state. Usually the candidates are poor surgical candidates, and lesions also can be widely placed. So radical resection may not be possible in all the cases. And they have fear of post-operative complications in the form of an osmotic leak, endocritinous fistula, peritonitis, sepsis, and obstruction and wound infection. So there may be chances of reoperation for recurrent obstruction also. Third is the most common type of surgery, which is being performed in the form of conservative surgery. The conservative surgery is the stricturoplasty, strictures causing more than 50% of the luminal compromise, and limited resection of the involved segment with primary anastomosis is usually done. And this is the most common type of surgery which is being advocated nowadays. So for non-resolving intestinal obstruction, which is refractory to medical and endoscopic treatment, this surgery is usually required for obstruction. And obstruction is the most common complication, mostly by the stricture in 50% of the abdominal tuberculosis. 1/4 strictures may heal with the medical therapy, but 1/5 will require surgery, and 1/3 of these are long strictures and less likely to respond to medical therapy. And another indication is that when there is healing and fibrosis, these strictures may exacerbate and also may lead to obstruction and will require surgery. So the surgeries are stricturoplasty and segmental resections. Stricturoplasty is safe and abnormal for both small and large bowel strictures. It preserves the gut length, and for isolated tubercular stricture with no associated mass-forming lesions or perforation. Resection is preferred during emergency surgeries or absence of definitive diagnosis like in Crohn's disease, or it is associated with perforation. So considering primary anastomosis versus stoma formation, it depends upon the general condition and other parameters and the experience of the surgeon. This is one of the pictures showing the most commonly performed surgical procedure. This is the stricturoplasty. The stricture is opened longitudinally and then closed transversely to make a wider lumen. And multiple strictures close to each other can often be resected. But if there is one dominant stricture, the stricturoplasty is a good option. So for perforation, obviously the surgery needs to be performed. The incidence is around 1 to 11%, and mechanism is due to obstruction. There may be a proximal blowout, or ulcer may eventually perforate due to the vasculitis, or there may be multiple perforations and where the strictures are common. So in this, usually patients present with peritonitis and sepsis. The outcome is poor with high mortality. And there is a significant diagnostic dilemma tailoring the surgical approach, that how to approach this perforation and what surgery to be performed. So already covered, like for emergency on acute abdominal perforation, the emergency laparotomy is required in 20 to 40% of the cases. And if there is a contained perforation like abscess, fistula, or massive bleeding, and in the form of ruptured nodal peritonitis, laparotomy and toileting may be required. So free perforation, usually lavage and resection is performed, or if the perforation is small, a primary closure can be done limited, but it has a limited role in patients with poor general conditions or with multiple perforations. And if contained perforation within adhesions or a cocoon abdomen, then abdomen is explored very carefully for recurrent SAIO, and careful adhesiolisis is done. And if any dominant stricture is found, then resection is and multiple drains are placed. And in case of serosal tears or enterotomy, multiple drains should be placed, and all these enterotomies should be lateralized. And there should be aggressive post-op care, and antitubercular treatment should be started as soon as possible, and nutrition supplementation may be required in these kind of cases. For bleeding, although it is rare in tuberculosis, but bleeding may be there, and massive bleeding usually requires emergency surgeries. When the localization is not possible prior to laparotomy, then the site of tubercular bleed may be identified on the morphological changes such as a stricture or a adjacent lymphadenopathy or intraop endoscopy may be used for the localization. And after localization, segmental resection is usually preferred. For the ileocecal mass, the patients which are not responding to the tubercular treatment or there is a form of obstruction, 10% might require surgery. And as already discussed, conservative surgery in the form of ileocecal resection is usually performed over more radical right hemicolectomy. And usually nowadays, a minimally invasive approach in the form of laparoscopy is also feasible, but literature has shown a longer operative time, but similar post-operative outcomes. Another is the cocoon surgery. This is the most common or the most difficult situation encountered by the surgeon. And the principle of surgery mainly are complete excision of the membrane by the sharp dissection, avoiding the use of a diathermy or energy sources because may lead to enterotomies or fistulae later on, and minimal manipulation of the bowel, and beginning the dissection from the inner side of the mesentery, then going to the interbowel during adhesiolysis. And if there is a perforation during adhesiolysis, better to resect it. And if there is a proximal enterostomy, then the primary goal is to overcome obstruction and avoid further iatrogenic injuries. And it has significant morbidity in the form of postoperative endocrine fistula, obstruction, burst abdomen, and mortality to the range of 13%. This is one of the intraoperative pictures showing a tubercular cocoon, and surgical principles as already described. In cases of peritoneal involvement, when they're not able to diagnose tuberculosis preoperatively, and we have a differential diagnosis of carcinomatosis, diagnostic laparoscopy may be required. And the visual characterization of the peritoneal disease can accurately predict in these cases, but usually the challenges are putting a first port. So either doing an open method or use thorough study of a preoperative imaging in the form of CT or MR to choosing a right port of entry is usually helpful. And there is a limited expansion of abdominal cavity in the form of, in where there is a peritoneal involvement, and the primary goal should be that we should have an adequate tissue for analysis, and energy sources should be avoided because of the cartridge artifacts, or the histopathologist may not be able to sample these samples later on. So sharp scissors or instruments should be used, avoiding the energy sources. And of course, when there is doubt of diagnosis, dissection can be performed and subjected to histopathology. A word about incidentally detected abdominal tuberculosis. It has already been discussed that if there is tuberculosis on a post-operative specimen, antitubercular therapy should be started. And if it has been incidentally detected during intraoperatively, then frozen section should be performed to rule out carcinomatosis. And if the proposed surgery should be proceeded if there is no carcinomatosis and or there is a doubt of chronic inflammation or tuberculosis, and a post-operative antibiotic therapy should be administered in these cases. Just a brief review of two case series from India highlighting what surgeries are being performed. This is one of the series from Central India, in which they have described 50 cases, in which almost 36% cases were emergency. And as we can see that the most common region was intestinal, followed by small bowel and ileocecal region. And most common finding was stricture, and most common surgical procedure was performed limited resection with end-to-end anastomosis, followed by adhesiolysis, and then more radical resection from right hemicolectomy, laparoscopy, stricturoplasty, and stomach closure. This is also one of the other study of more than 100 patients from probably Gujarat, and they have shown that most common surgery performed is limited resection of around 33%, and the most common intraoperative finding was strictures and ileocecal hyperplastic tuberculosis when the surgery is performed for intestinal tuberculosis. A word about endoscopic treatment, because nowadays endoscopic facilities are available at the centers of expertise. It should also be used whenever there is isolated stricture. It is a good alternative to surgery for readily accessible short and fibrous tubercular ileal strictures. The balloon dilatation is a safe option, but the experience is very limited, and the technique is safe and may obviate the need for surgery in this setting. To summarize, surgery is warranted for patients with complications such as perforation, abscess, fistula, bleeding, and high-grade obstructions. Patient with biliary obstruction due to stricture may rarely require biliary reconstruction. Intestinal obstruction is the most common complication, and patients with multiple or long strictures are less likely to respond to ATT. And obstructions may be exacerbated by ATT due to healing by cicatrization and fibrosis, and which may eventually require surgery. And surgical resection should be as conservative as possible, because there are high chances that patient might need a resurgery or reoperation later on. And multiple structures may be unable to strictureplasty to avoid major resections. Bypass should be the last options when not able to resect. And alternative approaches should be utilized, like balloon dilatation, if feasible and available. Thank you.
So thank you, Peeyush. You have tried to cover each and every aspect, but as you have tried to cover that there are different type of presentation of abdominal tuberculosis, and that's why probably different treatment has to be selected based on the acute presentation or chronic or subacute obstruction or perforation. Bleeding is a little bit less common. Obviously, internal fistulae, all these things are very common. I would just add to your what you said, that sharp dissection is what is required in a patient with when you are entering the abdomen in a case of cocoon, and it is very important to be very patient, and no finger should be used for the dissection. There are multiple evidence. There are multiple reports earlier, many years back, about the blunt dissection, we say with sharp dissection, and the dissection by the Mayo Caesar, very patiently, slowly going in between the two bowel loop, trying to make a plane and be very slow. One more thing I used to find entering into the preperitoneal space and taking bowel in front of you, and then trying to do slow adhesiolysis. Second important point is because entry is also very difficult sometimes in tuberculosis. Second important point is about there is a perforation. I think you highlighted. We should reiterate that in a perforation case, these people are nutritionally compromised. You must do a ostomy formation rather than trying to do any type of anastomosis, and then go start ATT and make the patient nutritionally viable for the surgery. Then definitive surgery can be done. And the rest of the things are, I think, covered everything. So, Kapoor sir, any important
One point I would like to mention for students and young colleagues, that if you are not sure by histology that it is tuberculosis, especially in an ileocecal mass lesion, where there is a possibility that it may be tuberculosis or malignancy, then it is better to do a formal right hemicolectomy as if you are dealing with malignancy, because it may be an overkill if it turns out to be tuberculosis. But on the other hand, if you do a limited resection and it turns out to be malignancy, then your treatment was not complete. So that is one. And second, if you're doing a strictureplasty, you must always, when you open the stricture, you must always take a biopsy from the edges of the opening so as to confirm your diagnosis. Mohit, would you like to make a comment on this, that earlier when we used to use streptomycin and PAS and other drugs, it was a very strong belief that anti-tubercular treatment will cause fibrosis and will lead to stricture formation and will lead to adhesion formation. Is it true that with the newer anti-tubercular drugs, the healing is not by as much fibrosis as used to be earlier? Is that true?
Sir, the thing is, there is no newer anti-tubercular therapy. Today, we will discuss the drug-sensitive tuberculosis therapy, sir. Second thing, we didn't discuss the MDR tuberculosis because only 6.8% of the total cases they will classify as an MDR, sir. We have data of 6.8% of the patients converted into the MDR abdominal tuberculosis because they have concomitant other part of the involvement is there. Either it is tuberculosis meningitis or pulmonary tuberculosis or genitourinary tuberculosis. So there is not a thing. These are the old drugs which we are using in the right now, but there is a definitive guidelines. Before we don't have any specific guidelines when to stop the therapy, when to start the therapy, when to follow up the patients. But right now we have clear guidelines. You have to start the antitubercular therapy in 2 phases. Intensive phase of 2 months. We can extend up to 4 months, depends on the clinical basis or radiological basis, and we have to continue with the intensive phase of the 4 to 6 months maximum. If the patient is streptomycin, sir, streptomycin is not indicated unless we need to modify the drug regimen, especially in the CLD patients. Sir. We are not supposed to start the streptomycin if the patient is drug-sensitive abdominal tuberculosis. We have to give H, isoniazid, rifampicin, pyrazinamide, and ethambutol. PAS comes in the MDR treatment regimen, sir. But still, MDR treatment regimen is totally changed right now, sir. And there are a lot of debate, and we can discuss it. 1 hour is still 1 hour. We can't discuss the MDR tuberculosis, sir. So today we just discussed the drug-sensitive tuberculosis. PAS initially we give in the drug-resistant tuberculosis. Still, we are giving in drug-resistant tuberculosis, but not in drug-sensitive tuberculosis, sir.
The other point from our surgical point of view, many of these patients, we put them on tube feed, either a nasogastric, nasojejunal, or feeding jejunostomy tube. So what is the site of absorption of these drugs?
So the thing is, you can give all the therapies through the nasogastric tube also. Because we are not giving injectables. All the drugs comes especially in India, sir. Sachet form is also there in India also, but prefer oral tablet forms. We can crush the drugs, we can give through the nasogastric tube, sir. Second thing, the absorption part, gastric absorption is there and intestinal absorption is there, sir. The main things happen in the metabolism part, sir. Isoniazid and rifampicin metabolized by the liver, while excretion of the ethambutol and pyrazinamide is to the renal excretions. That's why we modify the drug in the CLD patients and CKD patients. So we can give ATT through the nasogastric tube, percutaneous jejunostomy tube also.
And maybe I missed that part. Maybe you did mention, but maybe you can mention it again, that before starting ATT, we must get an LFT done. And when should the first LFT be done? After
Yes, sir.
how much time?
According to the guidelines, sir, 4 weeks.
4 weeks.
But if the patient is history of the chronic liver disease or history of recurrent jaundice is there, then better ask the patient to come 7 to 10 days with the LFT reports, if the patient is suspicious of any liver disease.
Dr. Sitaram, you would like to say something?
Yes, thank you. The problem of entry into the abdomen has already been mentioned. It can be very easy, it can be extraordinarily difficult, and a wide spectrum in between. So when you enter the abdomen in these patients, it's very important not to cause bowel injury, because you shouldn't add to the patient's problems by creating bowel injury which goes unrecognized. That's the first comment I want to make. This has already been mentioned. Second comment I want to make is, if you do a laparoscopy or a laparotomy, in order to get a diagnosis, you must make sure at the end of your procedure that you have sufficient tissue to make a diagnosis. Because you shouldn't be in the situation of telling the patient 1 week or 10 days later, I still don't have a diagnosis because the pathologist has said we are unable to say what the disease is. So frozen section in these patients should be done. What happens if you don't have frozen section facility? I don't have an answer to that. But it is better that in a place where frozen section facility is available, make use of the facility, get a commitment from the pathologist that the tissue is sufficient, and you have a diagnosis at the end of your operation. Third comment I want to make is, in situations when there is a perforation or when there is chronic obstruction, the bowel is edematous. And one contraindication for the use of staplers is edematous bowel. So avoid staplers in these two situations, because you are likely to end in trouble. You are likely to have anastomotic leakage and miserable problems after that in an already compromised patient. So hands-on anastomosis, traditional, probably much better than the use of staplers. Thank you.
Regarding the second point, tissue, I think if we are going in only for diagnostic purpose, we must take as much and as many tissues as possible. So I would say multiple enlarged lymph nodes, the larger ones, omentum, a piece of omentum, a piece of parietal peritoneum from the abdominal wall, and some people say even a liver biopsy. So because it should not be that even after laparoscopy under GA or laparotomy, we say that we don't have the diagnosis. So all this should be taken. And the third point, which Dr. Sitaram mentioned, no stapler. And if there is any doubt, no anastomosis. Just bring it out as a stoma and distal mucous fistula and let the problem be handled at a later date. TD, any concluding points? Otherwise, we can close. It is 9.
Yes, sir. I think we have tried to cover each and every aspect, and as I described that we have to be very, very careful in unlike any other abdominal situation, especially in adhesive obstruction and cocoon formation. As sir said that our aim, we should pray that we should not be making any enterotomy while entering and while doing our adhesive lysis. That is the final message. Thank you.
So, as I posted in the chat, I am very happy to see that yesterday's session already has had more than 300 views on the YouTube. So I'm sure that the efforts which all of you are making are benefiting students and practicing surgeons. So with that, I would like to thank today's speakers. And
Sir, there is a question on YouTube, sir.
Yes.
By Dr. Nimesh Tiwari.
Yeah, please,
Good evening,
take
sir.
that.
Yes, sir. Good evening, sir. What will be the treatment option in peritoneal tuberculosis if patient has already completed the treatment for 1 year and got recurrence within 6 months? So first of all, the chances of recurrence is more in clinical care, clinical suspected case, or histological proven, but not microbiological confirmed case. First thing. Second thing, before the recurrence is more in if the patient is not taking anti-tubercular therapy in proper dosage form. Suppose the patient is having weight of 60 kgs and he is taking anti-tubercular therapy of the 40 kg of the patient, the chances of recurrence increase. So the first reason is the patient was clinically confirmed or radiological confirmed, but not microbiological confirmed. Second thing, dosage form. Third thing, the patient, most of the patient, they are not taking their treatment properly. Either they have some drug-induced hepatitis, or they have drug-induced vomiting, they have recurrent nausea. So they just threw out their drugs out of the window. So we need to ask first of the cause of recurrence. Fourth thing, the risk factor associated with the abdominal tuberculosis. If the patient has the risk factor of a patient having HIV, or patient is consuming alcohol, or patient is having diabetes or CLD or CKDs, these types of the patients have high chances of recurrence. So before starting of the ATT, if the patient got recurrence, try to find out the cause of the recurrence. Don't start the ATT abruptly. Just the patient comes to you, he had a history of the 1 year of treatment. Second, there is no guidelines which says you can extend the treatment for 1 year. So find out the cause. Why do you extend the treatment for 1 year? Is there any complication was there? Patient was not responding, or patient has intermittently drug-induced hepatitis and you are modifying the treatment intermittently. So find out the cause of recurrence, find out the factors behind the recurrence, then you will start the treatment again and confirm. So if the recurrence you are suspecting, strongly suspecting recurrence, then confirm the case. either laparoscopically or either radiologically or any way.
So thank you, everyone. Thank you, Dr. Sitaram, for joining on both days, and hope to see you in more sessions of Jaipur Surgical Tutorial. Thank you. Good night, everyone. We will close the session. Good night.
Good night, sir.
Good night, sir.